to day 3 of our research week, session 2 of day 3, which will be focusing on SDG 3, good health and well-being, as well as SDG 11 on sustainable cities and urban communities, and the amazing work from our researchers at UWC in achieving these SDGs. We have a lot of speakers. We do have a couple of speakers who will not be able to make it this afternoon. However, I will jump straight into the first half of our session on health and start the session. So I'd like to introduce as my first speaker, Miss Samantha Kane-Cross from the Faculty of Natural Sciences. Samantha obtained her BSc in Medical Biosciences cum laude distinction in 2013. This was followed in 2014 with her BSc honors, also cum laude. In 2017, she obtained her master's degree in nanobiomedicine specifically, and she is currently finishing up her PhD in biotechnology, specializing in personalized medicine. And Samantha will be talking to us about personalized medicine, the discovery and validation of genetic markers associated with radiation-induced side effects in head and neck cancer patients in South African populations. Samantha, over to you. You've got 15 minutes.
Thank you so much for the introduction, Anna. Let's see.
Let me know. Perfect. We are starting to see it.
Okay.
If you can just put it on presentation mode.
Is this perfect, or should I put it on presenter view?
It's perfect.
So good afternoon, ladies and gentlemen. I will be speaking, or I will be presenting my presentation today titled Personalized Medicine, the Discovery and Validation of Genetic Markers Associated with Radiation-Induced Toxicities in Head and Neck Cancer Patients in South Africa. So cancer is this uncontrollable an uncontrollable proliferation or division of abnormal cells that eventually can become part of organ systems, cause organ dysfunction, and ultimately death. It has been projected that cancer will be the biggest killer in sub-Saharan Africa by the year 2030, surpassing surpassing communicable diseases, even though there's this perception nationally and internationally that cancer is not the problem in Africa. So radiotherapy is very important in the treatment of cancer and will play a critical role in improving disease outcomes now and in the future. So the aim of radiotherapy is to eradicate the tumor using radiation. In developing countries like South Africa, approximately 60% of patients will require radiotherapy as part of a treatment regimen. Okay, I'm just having trouble with the next slide. So radiotherapy is a cornerstone treatment for head and neck cancer patients, especially because a lot of these patients are diagnosed in the late stages where a more complicated treatment is necessary. And almost 75% of patients with head and neck cancer will benefit from radiotherapy. So why is this? So as you can see in the picture below, head and neck cancer would affect the head and neck area, which include our sinuses, our nasal cavity, which is our nose, our tongue, our larynx, that is where we speak from, as well as our throat and other structures in our head and neck area, right? And these structures are very important for certain functions, which include things like taste, smell, speech, sight, eating, and drinking. So radiotherapy is important because as opposed to surgery, it can preserve a lot of these functions after cancer treatment. In addition, we can think of the head and neck area as being a very sensitive area with abundant nerve endings, making surgery very complicated because we do not want to damage the nerves there. Also, our head and neck area is very important because this is what we usually present to the world, and for a lot of people, it is the source of confidence. And so we do not want to disfigure somebody using surgery. And this is all the importance, or this is where radiotherapy can really come into play. But radiotherapy, like other cancer treatments, are associated with side effects, also known as toxicities. So these toxicities can be divided into either early toxicities, consequential late toxicities, or late toxicities. So early toxicities, they can occur during treatment or less than 3 months following radiotherapy. These include things such as dysphagia, which is the inability to swallow, mucositis, which is severe inflammation of mucous membrane, causing ulcers and inflammation as well as infection, dermatitis, which is the breakdown of skin, and xerostomia, which is extreme dry mouth that can affect eating and drinking. And early toxicities can not only cause treatment stoppages, which could decrease or the prognosis of head and neck cancer, but it can also cause patients to abandon treatment because they no longer want to experience the difficulties. And then we get consequential late toxicities, and these are just early toxicities that keep on persisting for months on end that patients have to suffer through. Lastly, we have late toxicities. So these toxicities, they would occur about 3 months following radiotherapy, and they are really bad because after they worsen over the years and they affect the patient's quality of life, and patients tend to suffer with these toxicities for the rest of their lives. These include things such as osteonecrosis, which is the breakdown of bone, especially in the jaw area, affecting eating and drinking. Dysphagia, like I said, the inability to swallow. Trismus, which is the inability of a patient to actually open their mouths to communicate or to eat. Shoulder weakness, as well as radiation ulcers, which can cause infection as well as a lot of pain. So toxicities not only impact the human health, but it also impacts health costs as well, as when patients experience toxicities, it results in long hospital stays, more consultations with medical professionals, as well as additional treatment or intervention costs. This places a huge burden and stress not only on individuals, but families, and already overburdened health services as well as on society. So when it comes to the toxicities, we tend to grade them, right? So any toxicity, using the common terminology criteria for adverse events, which is a standardized criteria that we use to grade toxicities. So anything, for example, that is grade 1 or below is considered a control or not a toxicity. So these are usually very asymptomatic or mild. For mucositis, for example, which is inflammation of mucous membranes, it will be probably the patient has a little bit of a throat sore. But for grade 2 and above, for mucositis, this is what we would consider a severe toxicity, because now the patient is in so much pain that they have to modify their diet and switching to a liquid diet. And weight loss is also associated with a decreased prognosis when it comes to cancer outcomes. So we would divide it into toxicities and non-toxicities based on these grades. So the onset of toxicities show a large patient-to-patient variability in both incidence and severity, despite patients having similar treatment protocols, radiotherapy dose distribution, as well as any chemotherapy with their treatment. And there's evidence that radiosensitivity, meaning very sensitive to radiation therapy, is intrinsic to the patient, means that it's caused by genetic factors. That means that genetic factors will determine the risk of side effects, right? And this is exactly what we see in hospital, right? So a patient, because it is in our genetics, a doctor is unable to look at the patient face to face and could tell them which side effects they would be suffering from. So a doctor cannot, by looking at the patient, say you will experience side effects or you won't experience side effects, right? Because we can't see our genes. And so this is what we get, is that There are some patients that will go into treatment and they will experience no side effects whatsoever. They have the best treatment ever. And we have other patients that when they go into treatment, they unfortunately do not have a good experience and they suffer side effects that could last up to 10 to 20 years. So what is precision medicine or personalized medicine? It is an approach to patient care that allows doctors to select treatments that are most likely to help a patient based on the individual's genetic profile. Right? So it can be either the individual itself or whether we can expect it in a certain population. So if you can see in this image that I put over here, right now we have treatment without precision medicine or personalized medicine. That means that it is a blind treatment. All patients, they receive the same treatment and some benefit and others experience side effects. It cannot be predicted. But with personalized medicine or precision medicine, a patient would come into the doctor, would get a DNA test, and based on their genetic profile, would have a treatment tailored to them that's not only effective, but they would understand adverse outcomes associated with that treatment for them specifically. So what is the advantage of actually stratifying patients, right? So determining who are more radio tolerant, right, and who are more radio sensitive, meaning more prone to side effects. Well, more radio tolerant patients can have their radiation dose increase, as we can see on the graph, that as we increase the dose, there is a greater tumor control and there is a greater chance that the patient can actually be cured. But there are some patients who are radiosensitive, and for them, for example, having higher doses would result in bad outcomes or very adverse outcomes, right? So we would either opt for different treatment options or alternative radiation schedules specifically for them, or they can go into treatment knowing what to expect exactly and making that decision based on evidence. So genomic diversity within sub-Saharan Africa is relatively understudied as compared to the rest of the world. And radiogenomic output that we have at the moment is predominantly on non-African, so mostly Asian or European populations, right? And mutations or genetic biomarkers in genes tend to be prevalent in population groups. So the baselines and frequencies of established genetic markers differs between African, European, as well as Asian populations, and also between African populations. And there could be some unique markers in African populations as well. So the aim of our study is to discover and validate genetic markers associated with radiation-induced toxicities in head and neck cancer patients in South Africa. So first we got ethical clearance from the University of the Western Cape, as well as University of Cape Town, and we got special permission from Groote Hospital, right, situated in Cape Town. So our study population consisted out of head and neck cancer patients who have received radiation therapy, right? The ethnicity of the patients was determined by self-report, and we obtained informed consent before participation. The patient gave consent so that we could get the demographic, clinical, as well as the toxicity information from medical records, and to provide biological samples for genetic analysis. The biological samples was in the form of venous blood, where we did DNA extraction, and then we ran it on gene panels that we designed based on previous genetic markers that have been associated with radiation side effects, as well as other markers that would potentially play a role in the mechanism of action when it comes to radiation. We then collected other data, which includes radiation dose, age, ethnicity, smoking history, previous surgery, disease stages, histology, as well as other patient histories. We graded these side effects, and then we perform analysis using SPSS. So our results show that for acute skin, first we used a cohort of 35 patients, and in these patients we saw that one genetic marker was associated with an increased risk of patients experiencing skin toxicity, as indicated by the red arrow. And then we have one genetic marker that was associated with a decreased risk for skin toxicity. We then went on to collect a total of 162 samples in which we saw what these frequencies or how frequent or prevalent they are in our population for our genotype panel. And as we can see, some markers that were investigated in other populations were not even present in our population, but still it was a limited sample size, and hopefully in the future we can improve the sample size. We then selected patients based on inclusion criteria to do a study on mucositis or early toxicities. And we found that 137 patients reached our inclusion criteria. And out of these, we discovered that there is a genetic marker associated with the increased risk of patients experiencing mucositis. We then screened patients to see who would meet our inclusion criteria for investigating late toxicity. And we discovered that there were 3 genetic markers, as indicated by the red arrows, that were associated with the increased risk of experiencing late toxicities, whereas there was one marker showing that these patients were at a decreased risk for experiencing late toxicities, meaning that they could probably receive higher doses because they would be a bit more radiotolerant than the others who contain the genetic markers indicated in red. So in future, we hope to adjust the results to covariates, include more toxicity endpoints, compare the frequencies of these genetic markers in the South African population to other populations, and compare the frequencies of genetic markers amongst the different ethnic groups in South Africa as well. To our knowledge, this is the first radiogenomic study done in South Africa. We have discovered potential diagnostic biomarkers to predict the onset of early and late toxicities following radiotherapy treatment in South Africa. And the significant markers in our study have not been investigated or have not been significantly associated with head and neck cancer toxicity in other studies. The genomic information gathered from radiogenomics can be integrated into a clinical setting to help make evidence-based decision-making and can help form local patient treatment guidelines that can lead to better patient quality care, service improvement, as well as financial planning. As we know that in South Africa, we have a large out-of-pocket expenses when it comes to medicine. We don't have universal healthcare yet. And identifying genomic markers relevant to the population could also result in cheaper genetic testing. That means that we can only select for markers that are relevant to our population. With radiogenomic studies like these, it will be possible to implement locally appropriate strategies to treat cancer. Thank you so much for your attention. Thank you.
Thank you very much, Samantha. What an interesting project. I have to say it's very dear to my heart, cancer and specifically personalized treatment to improve outcomes. So really amazing work. Thank you very much.
Thank you so much. Thank you.
We will leave questions for the end of the first half of the session. Please, I'd like to ask the audience to either type in the questions in the Q&A section or the chat section. And we will either answer them as another speaker speaking, or we'll leave it for the Q&A a little bit later. To not waste any time, I'd like to present the second speaker, Ms. Sihle Mamutse from the Health Promotions and Wellness Unit. She will be talking to us about reflections on peer-to-peer led interventions, looking at the way peers are disseminating information. Sihle, over to you.
Yes, thank you so much. I will just start sharing my slides. Here we go. Thank you for, I hope my audio is not intense.
It's perfect.
Problems. Thank you so much. I am Ms. Sihle Mamutse. I'm from the Health Promotions and Wellness Unit here at the University of the Western Cape, and I'll be presenting on reflections on peer-to-peer led interventions, looking at the way peers are disseminating information. So I'll be focusing on introduction to peer-to-peer intervention programs, importance of evaluations, and I'll look at my objectives and types of evaluations, knowledge gaps, assumptions and framing in peer-to-peer interventions, and conclusions looking at the urgent need for research. The World Health Organization recommended sexual health approaches to emphasize youth-centered participation. This included peer education, which is a common method in low resource and high HIV prevalent settings that promotes HIV prevention and sexual health. And these programs often assume peer-to-peer conversations which address health challenges such as STIs, gender-based violence, and mental health, among many others, within a knowledge dissemination framework. And the primary aim of my presentation is to highlight the extent of program evaluations and the types of evaluations conducted within peer-led interventions. And there's growing evidence that supports that the effectiveness and the campus-wide adoption of these peer intervention programs. And these address so many issues, which also include unplanned pregnancy, and there's a growing popularity that many campuses are actually implementing and taking up these kind of interventions. So my objectives, I'll be looking at I'll evaluate the impact and effectiveness of peer-led interventions in South Africa in modifying young people's behaviors, and highlight the need for comprehensive program evaluation and the critical reevaluation of assumptions underlying peer-led interventions. And this will also emphasize the importance of contextualizing peer-led interventions within the experiences of peers, and then advocating for a critical approach to health and wellness in the South African context, and eventually assess the effectiveness of peer-led interventions in modifying young people's risky behaviors, especially in South Africa, which will provide valuable insights into the impacts of these programs. The presentation utilizes a narrative review approach to examine the extent of and nature of these programs. And I drew on evidence from peer-reviewed articles, WHO and UNICEF, and government reports, qualitative studies and quantitative studies, systematic reviews, and overall overviews. So this comprehensive methodology allowed me to examine the effectiveness of peer-led interventions, especially within South Africa. So research shows that methods of evaluating peer-led interventions usually take up pre- and post-intervention surveys. And some studies use generalized estimating equations for data analysis and comparison studies between intervention and control groups, while other studies are also using interviews, focus groups, and mixed methods. However, these evaluations predominantly assess the impact of peer-led education on HIV prevention, sexual and reproductive health outcomes among young people. And they utilize diverse study designs and techniques to weigh up the intervention effectiveness, while it's also appraising the knowledge and the skills of peer educators their skills are appraised, especially when it comes to the specialized training programs that administered before they become peer educators. So while there's a wide range of evaluation happening, there's limited data. There's not that much data that actually speaks to how effective and how sustainable these peer-led interventions are. And not many studies are done in South Africa. And with this, evaluations are examined through young people's perceptions of trial procedures and peer-to-peer methods and HIV self-testing packs and sexual health information. So findings around these only indicate that peer-to-peer approaches resonated well with young individuals, which fostered a sense of connection and the distributing linkage of information and access to sexual health information through the peer educators did have positive feedback from the actual peer educators who were involved in these studies, in these evaluation studies. And an evaluation by the Vishulo peer educator program in South Africa indicated that the program improved supportive behavior, and especially when it comes to HIV and AIDS, sexual and relationship health, and it had good attitudes. It established good attitudes among peers, and this was all prevalent with also some of the interventions that were evaluated. However, the study did face a lot of methodological challenges related to designing a comprehensive evaluation and evaluations that are both time effective and cost effective. So other evaluations of South African adolescent peer programs, they also yielded, there wasn't really much significant impact on student sexual behavior or psychosocial outcomes. So this showed that programs that are individualized, especially curriculum-based programs, it didn't, whether they're facilitated by peers or teachers or any other person, they did not have any substantial impact on changing the behaviors of peers. And if these programs did not include a social, political, and economic factor when in impacting peers' lives, it wasn't going to be as effective. And these studies range and types of studies are limited to develop best practices. So when it comes to knowledge gaps, we found that lack of evidence for effectiveness or coverage was a part of the problem. So many programs were unable to provide evidence to demonstrate their effectiveness or coverage. And data mainly limited to numbers that reached small number of people, or anecdotal evidence that did not have much substance. And also the evidence was only acceptable in terms of its reach to adolescents and their caregivers and their feedback on those peer-led interventions. And also available data was not readily accessible or in a format that people could actually share and scholars would actually look at. And this highlighted the need for programs to strengthen their data and make data more accessible. Another knowledge gap was data and the need for additional evidence. So in this case, several areas require additional evidence, and especially before scaling up these peer educator programs. And these data gaps need to be addressed to show the effectiveness of the programs and the effectiveness of the implementation and the service delivery for the programs to improve. And there's also a need for age disaggregated data. So in this case, data is becoming more available to inform adolescent HIV programming, but the collected data and the national reporting is a bit scarce. So collecting and reporting subnational data on adolescents is important for identifying data gaps and informing program planning at the subnational level. Another thing is that there is a lack of evidence on the minimum package of services required to have a positive effect on clinical and psychosocial outcomes. So identifying this minimum package of services and to make sure the effectiveness of program is actually, the implementation of programs is actually effective, these data is identifying this minimum package of services is actually crucial, especially if we want to scale up these peer educator interventions. And lastly, multi-sectorial approaches and linkages to services. So it is crucial for us to address the complex needs of adolescents, and especially adolescents living with HIV, and ensuring they have access to various health services and improving the social services that they get. And furthermore, exploring alternative strategies for improving linkages and referrals to health services, encourages innovative and creativity. It encourages innovation and creativity. It makes the interventions more effective and more sustainable. So when it comes to, sorry, I lost a bit of network there. Can you still hear me?
Yes, we can. And you were on the slide.
Oh, okay. Thank you. So another thing is the influence of peer norms on peer educator interventions. So peer-led interventions can promote behavior change by understanding the cultural factors and the group norms that exist among peer educators and their peers. And familiarity with peers allows for an open discussion on sensitive topics that increase peers and peer educators' participation on, and also take ownership and encourage taking up ownership of their own health. And this helps to recognize young people as partners in decision making, which increases also their participation, as opposed to just looking at peers and peer educators as passive recipients of these interventions. And another thing is peer-led interventions recognize the importance of social networks and social networks in shaping the behavior of peer educators and their peers. And in this case, they assume that individuals who are closely connected to peer leaders or influential peers are more likely to be exposed to the intervention and adopt the desired behaviors. And also there's an importance to personal engagement. So peer-led intervention assume that personal engagement in interactive activities are more effective in promoting behavior change than passive methods. So by involving the peers in disseminating information about health concerns, health risks, and especially HIV and AIDS, mental health, gender-based violence, these interventions aim to increase the impact and reach of these messagings. And another is the importance of trusted adults. Even though these are peer-led interventions, involving trusted adults enhances youth behavior by increasing engagement and receptivity. Peer leader messaging will be enhanced and thereby enhancing effectiveness of programs. And another thing is complementing interventions to other intervention strategies. So in this case, peer-led interventions assume that they can complement other intervention strategies designed to reach higher risk areas, such as the retention of the programs, the adherence of programs, and access to sexual and reproductive health services, among others. And another issue is addressing systemic risk factors like poverty, especially within the South African context. Poverty significantly affects peer-led interventions, especially in areas of sexual health, HIV prevention, mental health, and gender-based violence among young people. And addressing these socioeconomic inequalities in South Africa is very crucial for developing tailored strategies and evidence-based approaches to improve the effectiveness of already existing and newer peer-led interventions. So contextualizing peer-led interventions. So contextualizing emphasizes tailoring components in peer-led interventions to South African young people's needs and preferences. So this is
2 more minutes, Cecilia.
So this is familiar communication styles, online avenues, and peer-led interventions, right? Furthermore, understanding cultural factors and social norms helps engage peers and promote behavior change. However, when contextualizing peer education programs, one can face challenges due to ongoing training, support, and supervision costs that also come with trying to implement interventions. And understanding the cultural context and adapting programs can effectively promote positive behavior change. Another thing is to improve engagement in preventive interventions, such as the Fushilo Peer Educator Program in South Africa. We must consider alternative strategies that enhance effectiveness and tailor solutions to the specific context, and also encourage innovation. So this can lead to improved sexual health education and HIV prevention among young people, making interventions more effective and sustainable. And lastly, future research on peer-led sexual health and HIV prevention among young people is crucial. And it requires strong study designs which address implementation issues and addressing social determinants of health and structural barriers. So future research should focus on more rigorous evaluations of peer-led interventions and explore the impact of HIV positive adolescents and identifying effective implementation strategies, and actually include these peers into the peer-led interventions for a more rich and effective interventions. And clearer program evaluation guidelines need to be implemented, and sharing best practices among institutions can improve mental health programs, especially with contextualizing all these programs and all these issues and problems that peers are facing into collaborative and programs that can actually use resources from each other in order to drive change. And the changing landscapes of post-secondary mental health necessities should be integrated into these interventions, both to address the physical and mental health of peers across campuses in South Africa. Thank you.
Thank you very much, Sige. Very interesting. And I really liked the fact that you mentioned the importance of looking at the socioeconomic inequalities and the effect that it actually has, because it's more than just having these peer-led interventions, but it's looking at the environment around. So very, very interesting. Thank you very much.
Thank you.
With that, I want to again invite our audience to send us questions on the Q&A or the chat. We will deal with the questions a little bit later. And before that, I'd like to invite Ms. Nabila Ibrahim from the Faculty of Community Health Sciences to come up and talk to us about the determinants of falls among the elderly living in long-term care facilities in the city of Cape Town. Nabila, over to you.
Hi, good afternoon. Thank you, Anna, for the introduction, and thank you for the opportunity to present. I just want to share my screen quickly. Okay, can everyone see my screen?
Yes, I can see it perfectly. No, it's not on the way.
Okay. Good afternoon, everyone. So my topic is the determinants of falls among the elderly living in long-term care facilities in the city of Cape Town. And my professor is Prof. Lloyd Leach. So, why is this not? Okay. So just a overview definition of what a fall is. I use the one from the World Health Organization, which is defined as an incident which causes a person to unintentionally rest on the ground or floor. So just the scope of this study. So according to the World Health Organization, those aged 65 years fall about 28 to 35% each year. And as age increases and frailty level increases as well, then fall also increases. So falls are generally the most common cause of injury-related death, especially those who are above the age of 75 years. and many falls are associated with one or more identifiable risk factors such as weakness, unsteady gait, confusion, and types of medication, which are only a few of the risk factors mentioned here. It's usually caused by interaction of many different risk factors, and therefore the identification and removal of those risk factors associated with fall is a high priority. So within South Africa, we have the highest population of elderly in the African region, which accounts for 8.7%. And most studies among the elder views on the risk factors of falls, fall injuries and preventions is very scarce, especially those living within these long-term care facilities. So approximately 1,800 elderly living in these facilities, they die annually due to fall-related injuries, and many of them aren't reported at all either. 70% of the aging population resides mostly in the lower middle income countries, where the prevalence and incidence of fall continues to increase and are considered very largely elevated. So within this low middle income, it's basically to do with environmental factors, which could be a huge contributor to the intrinsic causes of these falls because of reasons, for example, like the poor infrastructure in most of the areas, the poorly maintained environments, roads, public buildings, etc., and like the limited access to healthcare resources. So the aim of the study was to identify the determinants of the falls among those within the long-term care facilities, and then just to broaden awareness of what the impact of biokinetics have on the elderly population. So for my research design, I used a quantitative cross-sectional study. Cluster sampling method was used to recruit the participants via the Slovens formula. And the study was conducted within 15 long-term care homes and during the COVID-19 pandemic as well, where 10 of the facilities were public and 5 were private ones, and in the areas of the Atlantic seaboard, southern suburbs, the northern suburbs, during COVID-19. So my inclusion criteria was those already 60 years or older within these long-term care facilities, and of course within Cape Town, male and female living at least for 1 year minimum within these facilities, and those who are fully ambulatory that didn't need any support. My exclusion criteria was those not within the community, so directed to those in the facilities, basically, and those who are unable to communicate with severe medical problems, and then those with using a wheelchair or any form of walking aid. My instruments that I used, so there were 5 different instruments that I used. One was the fall risk assessment tool, which was basically used to categorize either as being high, moderate, or at low risk of falling. So this assessment was comprised of 2 parts. The one part was to obtain the risk score, so whether you were high, moderate, or at low risk, and then part 2 indicated the risk factor checklist, in which you were at minimum to get a to have already a specific risk factor, for example, like poor vision. And then I used the Berg balance scale, which was a physical assessment to objectively determine static balance. And then as you'd go through it, you'll just lose points, and the maximum points was 56. What I used also was a dynamic gait index, which assessed 8 components of gait and was used to determine the functional balance of the participants. So basically the ability to respond to different task demands and not lose balance while they were walking. The timed up and go examination was also used to determine the fall risk and their process of balance. So they were instructed to stand up from a stool, walk 3 meters, turn around, walk back at their normal pace and sit down. And this was calculated, hence time up and go. The mini mental state examination was a cognitive test, which included a questionnaire that assessed their cognition regarding their orientation, registration, attention, calculation, their memory, language, as well as their visual spatial skills. For the statistical analysis, SPS version 28 was used. I used a range of descriptive statistics. The chi-square test was also used to determine association between categorical risk factors, and then the Kruskal-Wallis test to determine differences between the assessment tools and the 4 mechanisms as well, and then the general 0.05 p-value for statistical significance. So going on to the results, from the study, 57% used non-profit organizations, which was slightly more than half. 74 were males, of which the majority made up females, and most of the participants fell in the age categories of 70 to 79, as well as 80 to 89 years old. 40% had a normal weight, and 33% of them were overweight. 40% of them had tertiary education, and almost half of them were widowed. There was a total of 91 falls within the past 3 months while staying in this long-term care facilities, and most of the participants were medicated with antihypertensive medication. So there was 32.6% of participants who had a fall, with more than half not sustaining a fall. Falls were related to slipping and tripping, was the main fall mechanism. And those related to loss of balance and dizziness was not as high, but was more than the amount of participants who fell during collapsing as a fall mechanism. So I hope you can see this table. So regarding my variables, facility type, results indicated that most of the participants from the NPO facilities were more at risk for falls compared to those from private facilities. And those, like explained, because of probably attributed to facts like reason that maybe they were understaffed, they had minimal resources, and cost cutting, whereas private facilities had the financial means to assist the residents, and they could give one-on-one care. With regards to educational level, those with lower education level showed a high number of falls, could possibly have difficulty understanding fall prevention information, or why a fall prevention program was necessary among the population. And then also among marital status, it was significantly associated with falls, with both genders also had equal prevalence of falls. Those who were married were more likely to have a lower risk of falling compared to their counterparts, which indicated that being widowed was related to an increased risk of falling, indicating that having a partner contributed to a higher level of social support. And these are one of my graphs indicating the different fall risk factors that came from one of the assessment tools. The other risk factors of other referred to that not included in the study. So you can quite clearly see that the females, which are indicated as the red bars, had a much higher fall rate among all the risk factors compared to the males, and that poor vision was one of the main risk factors that was an issue in those facilities. With regards to the risk factors according to the age, so like I've mentioned earlier, ages between 70 to 79 and 80 to 89 years were made most of the participants. And you can, the 80 to 89 years is the orange bars, of which nutrition, ADLs, transfers, and other risk factors. And then between the ages of 70 to 79, unsafe footwear and continence, as well as poor vision, was of the main risk factors. And then the purple bars in the front was the 60 to 69 years. And that was basically quite high among the risk factors of environment and mobility, which was quite interesting because once residents had to move into a facility, which was round about that age span, they found it very difficult to adapt to their environment and things like that. And then those that really, the 90-year-old was the green, which is the right in front, the bars right in front. And many of them just indicated that 4 risk factors relating to ADLs, which was the most prominent. And these were, the rest of the risk factors were quite low due to things like maybe residents who were mostly bedridden. So they would struggle mostly with things like grooming, needing to be fed, etc. With regards to the 4 risk status, the 4 risk assessment tool, which was broken up into recent falls, number of medications, psychological status, and cognitive status. You can see that right at the top in the yellow block, according to the recent falls, most of the participants, which was 171, was at low risk. They didn't fall in the past 12 months regarding number of medication, just below. There was quite a large amount of people that took more than 2 medications. And then regarding the cognitive status, most of the residents cognitive status was intact. Moving down to the purple section, which included the Berg balance scale, most of them were at low risk of falling, and most of them were also safe ambulatory regarding the dynamic gait index. And then with regards to the other cognitive assessment, most of the residents had early stage dementia. And then the prevalence of falls was 32.6%. Like I mentioned, most of them were at low risk, 40.5% at moderate, and only a small percentage were at high risk of falling. Poor vision, concerning behaviors, and unsafe mobility was of the highest prevalence amongst gender. So the determinants of fall were strongly associated with facility type, level of education, and marital status, as indicated earlier. And then antidepressant and antidiabetic medications were those drugs that were significantly associated with falling, which was quite interesting because most of the residents use antihypertensive medication. So the time up and go and Berg balance scale assessment were significant with determining the risk of falling. So the strength and limitations of the study. The strength were the use of the variety of assessments rather than just one assessment to determine participant falls, and the fact that it was also a once-off assessment, which decreased the probability that participants would either pass on or be hospitalized when the reassessment had to take place. For the limitations, recall bias among the participants of their fall injury limited the validity of the findings. And because data collection took place during the COVID-19 pandemic, which only yielded a 72.3% participant rate response. The fact that I only focused on those living within the long-term care facilities and excluded those who were frail, those who were wheelchair-bound or bedridden. So the findings from the study could be useful. Thank you. Could be useful in a clinical setting within the long-term care facilities, and the purpose was to provide research-based evidence on the determinants of falls, to shed awareness to control the amount of falls, and then focus more on the quality of life and maintaining independence for these elderly. So with the knowledge gained from the study, along with future follow-up studies, biokineticists in combination with other health practitioners, such as physios, OTs, are in leading position within the elderly care institutions to contribute towards this large concern. So just a small take-home message. The study was basically analyze the elderly living in these care facilities. It emphasized the importance of the determinants of falls, which increases the risk of their functional decline. And this in turn had a dreadful impact on maintaining independence and the quality of life among our elderly population. So my question to you is it there not need to implement the proper healthcare professionals to assist with the sector? Thank you so much.
Thank you very much, Nabila. What interesting findings. I have to say, I've learned a lot. I didn't know that falls were actually the most common cause of injury-related deaths in elderly. That's mind-blowing, because I guess there's both the direct and the indirect effect of breaking a bone, going into surgery, your heart gives up because of the surgery. So very, very interesting. Can't wait for the question slide. Thank you very much.
Thanks so much, and I appreciate it. Thank you. Have a good day.
With that, I'd like to call up Mr. Devald Schoeman. He's from the Faculty of Natural Sciences. He's a PhD student in the Molecular Biology and Virology Research Laboratory at the Medical Biosciences Department, supervised by Prof. Fielding, and co-supervised by Ruben Klutter from Sanby. Very interesting. And he's going to be talking to us about the flexibility of the E protein PDZ binding motif potentially plays a role in the virulence of human coronaviruses. Devald, over to you.
Thank you so much. Let me just share my screen. Okay. Thank you for signing into this session this afternoon. I'm going to be presenting to you on some of the data from my PhD project, specifically the bioinformatics part, and the data suggests that the flexibility of the E protein, which has a PDZ binding motif, may potentially play a role in the virulence or the severity of human coronaviruses. So I'm sure by now, after COVID-19, many of us, if not all of us, have heard of coronaviruses, but not everyone may know that there are 7 coronaviruses that can infect humans. So all of them can infect humans, and they generally cause respiratory tract infections. So because they all cause disease in humans, we say that they are all pathogenic, but they are not all pathogenic to the same extent, or they don't all cause disease to the same extent. So we classify them based on the severity of disease, either as more virulent or as less virulent. So the first 3, SARS coronavirus 1, MERS coronavirus, and SARS coronavirus 2, have caused deadly outbreaks in the last 20 years. SARS coronavirus 1 has caused SARS back in 2002, 2003. The MERS coronavirus has caused the MERS outbreak in 2012. And of course, the SARS coronavirus 2 caused the most recent COVID-19 pandemic. The other 4 human coronaviruses are classified as less virulent because they are quite common and they generally cause mild to moderate respiratory tract infections. So these are human coronavirus 229E, NL63, OC43, and HKU1. But regardless of the severity of disease that they cause, all 7 of these human coronaviruses have the same structure, as you can see here on the right-hand side. They all have the spike protein on the outside, or the S protein, that's used to attach to our cells and infect the cells. They also have a nucleocapsid, or N protein, a membrane, or M protein, and an envelope, or E protein. So all 4 of these proteins, the S, N, M, and E proteins, form the structure of the virus, and so they are called the structural proteins, and they all surround finally on the inside the RNA viral genome, or the genetic material of the virus. So the envelope protein, which is the one I focus on for my project, is the smallest of all of the structural proteins, but it is still found in all coronaviruses and human coronaviruses. Now, the primary function of the E protein is a structural one. It is a structural protein, and it's specifically involved in the assembly of new virus particles. So as you saw on the previous slide, it forms part of the envelope of the virus, so it assists to assemble new viral particles. It's also involved in the release of those newly produced viral particles so that they leave the infectious or the infected cell, and then they can go and infect more cells. But the E protein also has a secondary function linked to pathogenesis, or pathogenesis is basically how the virus establishes disease, and then how the disease progresses. So the E protein is involved in pathogenesis because it binds to proteins inside the infected cell. We refer to this as viral host protein-protein interactions. And the way that the E protein can do this is because it has at the end of the protein this PDZ binding motif. So it's kind of a long winding name, but basically a lot of the proteins inside our cells have a PDZ domain. We can basically think of it like a lock and a key. So the PDZ domain is on our host cells, or on our cells inside, proteins inside our cells. And then the E protein of the virus has a motif that allows it to bind to the PDZ domain. So it's like a key that fits into a lock. And the virus then is able to exploit the proteins inside our cells to promote replication of the virus. And so for this reason, actually, the E protein has been shown in previous studies to be a major contributor to viral pathogenesis. Previous studies that have either removed the E protein from the virus completely, or that have removed just this PDZ binding motif, have found that the virus afterwards is significantly less severe. The disease is much less severe than when the E protein or the PDZ binding motif is present. So the research on the E protein is, unfortunately, there's very little research. It's not as well studied as all of the other structural proteins. But in saying that, for the more virulent coronaviruses, such as SARS-CoV-1, SARS-CoV-2, and the MERS coronavirus, those have received the most attention, understandably. So most about what we know of the E protein comes from studies on those viruses. Unfortunately, when it relating to the less virulent coronaviruses, such as 229E, NL63, and OC43, and HKU1, there's quite close to nothing, almost nothing on the envelope protein and how it functions in those less virulent viruses. So I want to bring your attention to a paper that was published in 2010. They found, specifically at that time, only the SARS coronavirus 1 had broken out already, but they found that the E protein of the SARS-1 coronavirus is able to bind to a specific protein inside the cell called PALS1. So if you see here in the picture, this little green dot over here is PALS1. And inside the cell, PALS1 is normally associated with what we call a tight junction. It's a structure that allows cells to remain attached to one another and basically helps to give structure to our tissues and organs. So what the study found was that the SARS-1 E protein, in yellow you can see over here, is able to bind to the PALS1 protein, and that prevented the PALS1 protein from being associated with the tight junction over here. And the result was that the cells where the PALS1 protein were no longer at the tight junction, these cells started breaking down, and basically the tissue started breaking down, and this allowed the virus then to gain access to the bloodstream and then is able to spread to other organs in the body. So with this in mind, we chose for my project to look at the PALS1 host protein as a potential interactor with the envelope protein, because the PALS1 protein is fairly well characterized in terms of this protein-protein interaction, but also the PALS1 protein only has one PDZ domain. Some other host proteins have more than one, so we know with PALS1, there's only one PDZ domain, so that's the only place where the E protein that we're looking at can bind to. So with all of this in mind, the question that we asked for this chapter of my research is, can the E protein of the less virulent human coronaviruses bind to host proteins in the same way that the E proteins of SARS coronavirus 1 and SARS coronavirus 2 do? Because the E protein is able to bind to your cellular proteins, but it is not clear whether the less virulent human coronavirus E proteins can also do that in the same way. So basically, we want to see, is there a PDZ binding motif in all 7 of the human coronavirus E proteins? But more importantly, are those PDZ motifs actually functional or not? So to achieve this, well, we did a few things. We first had to make full-length 3D models of each of the E proteins. So for each human coronavirus, we had to make an E protein model, and we did this by a process called homology modeling, and we used a software called Modeler to produce those models. We then took those models and we docked them, or we simulated how the E protein might interact with the PALS1 protein through a software called Haddock 2.4, and this allowed us to see which of the E peptides or proteins could bind and how they could bind to the PALS1 protein. So after we did the docking, we analyzed those interactions using a web server called PLIP, or Protein Ligand Interaction Profiler. So basically just profiling this interaction between the E protein and the PALS1 to see where are the interactions taking place and are there any interactions taking place between these 2 proteins. And lastly, we then took these complexes after analyzing the interactions and we performed what we call MD, or molecular dynamic simulations. So we wanted to see over a certain time period, how do these 2 proteins interact? Do they change their structure during the interaction? Do they stay connected to one another or interacted? Or do they separate from one another at some point in time? And we were able to do these simulations using the software called GROMACS. So just a bit more about how we made these models through homology modeling. We needed a template first. So there was an experimentally resolved or experimentally understood or discovered structure of the SARS-1 coronavirus E protein. And the ID for this protein structure is called 5x29. There was a second one we also used, depending on which a better fit, and the other one is called 2MM4. Those are just the IDs for those specific structures. But both of those we used as a template so that we can then tell the software modeler to tell us how to make 3D full-length models for all of the envelope proteins of the human coronaviruses. So with this in mind, we made 5 models, full-length models spanning the entire length of the E proteins for 5 of the human coronaviruses. That's SARS coronavirus 1 and 2, the MERS coronavirus, and 2 of the less virulent ones or the less severe ones, 229E and NL63. So we have our models through this process. We then took these models and we performed docking using the Haddock 2.4 web server. And we didn't take the entire protein. We only took the last 8 amino acids in the E protein, which then also contained the PDZ binding motif to allow the peptide to bind to the PALS1 protein. And the reason we did that is because there is experimental evidence available in studies so that we can compare our data, which are largely based on simulations, so we can compare it to actual experimental data. And then we used the PLIP server. Here's the link that we used to the web server in order to see which interactions took place between our peptide and the PALS1 protein. And we could then also use the experimentally resolved structure, the experimental data from a previous paper, to validate our findings. Do our simulations compare to the experimental findings, or are they different to those experimental findings? And the specific structure that we were able to compare our simulations to is called 7NTK, which is a structure of the SARS coronavirus 2 E-peptide that is complexed with the PALS1 protein. And then lastly, we performed our molecular dynamic simulations. We had to first prepare input files to just prepare all of our files before we could run the simulation. So we used the Charm GUI web server to put our peptide protein complexes in a small box, similar to when we work in the lab. You would perform experiments either in a tube or a certain plate or a flask. So we placed our complexes of the peptide and the protein in a 7.1 nanometer box to confine the simulation, basically. We then solvated or added TIP3P water molecules to simulate an aqueous environment. And then we basically added ions, sodium chloride, to a concentration of 0.15 molar to also simulate a physiological pH to basically represent as close as possible to physiological conditions inside the cell as we could. So once we were able to generate those input files, we used GROMACS to run the simulation. We minimized our structures just to make sure that there are no unstable interactions between the proteins or the peptides, just make sure that all the bonds are stable. And then we equilibrated it at the standard temperature and pressure, basically to simulate how you would perform experiments at room temperature. And then we ran the actual production run for 500 nanoseconds. So this 500 nanoseconds reflects a time on a biological scale. So it's not 500 nanoseconds in the sense of less than a second in real time. It's 500 nanoseconds on a biological scale. And then once the production run was done, we performed an analysis of what we call the trajectory or the production run. We looked at 4 parameters, basically: the radius of gyration, the RMSD, the RMSF, and the interaction analysis. So these are all 4 standard analyses after doing a molecular dynamics simulation. But for the purpose of this presentation, I will only show you the results of the radius of gyration and the RMSF. So what did we find? Sorry?
2 more minutes.
Thank you. So we found in the models that the top 3, A, B, and C, were your more virulent human coronaviruses. And specifically, as you can see over here at the end, the PDZ binding motif is a flexible, extended, what we call a loop region. So it's quite flexible compared to the bottom 2 coronavirus E proteins, the less virulent ones. That same PDZ binding motif adopts an alpha helix, which is less flexible than the loop for the other 3. When we compared it to previous studies that also made models of the E proteins, we found that for SARS-CoV-1, SARS-CoV-2, and MERS, they also had a loop region where the PDZ binding motif was. However, for our study, we were the first ones to only make E protein models for the less virulent human coronaviruses. So this table shows us that at specific residues on the PALS1 protein, there were important interactions that were made between the E proteins and the PALS1 protein. As you can see in the red boxes, the more virulent human coronaviruses made quite a few interactions at these important points on the PALS1 protein, but in green, the 2 less virulent human coronaviruses did not make all of those important contacts. So it seems that both the more and the less virulent coronaviruses could interact with PALS, the host protein, but the less virulent human coronaviruses did not interact with PALS1 as effectively. When it comes to the molecular dynamics simulations, we found that there were no significant conformational changes. So the binding of the peptide to PALS did not significantly alter the structure of the PALS1 protein. You can see that as well with the flexibility of each of the residues. Unfortunately, I don't have time to show you the simulation or the video right now, but basically for all of the more virulent human coronavirus E peptides, they remained attached to the PALS1 protein for the full 500 nanoseconds. But when it came to the less virulent human coronavirus proteins, 229E and NL63, they started to detach. If you have a look here at the end of this graph over here, this long upward projection indicates there was a lot of flexibility. So the E peptide actually detached from the PALS1 protein. And we can see the same thing over here in the NL63 E peptide, that it detached from the PALS1 protein. So in essence, all of these results shows us that the more virulent human coronavirus E proteins, their PDZ binding motif is more flexible, whereas the less virulent human coronavirus, their PDZ binding motif is less flexible because it's an alpha helix. They could all occupy the same binding site on the PALS1 protein, but there were some differences, with the less virulent E proteins not making all of the important contacts that the more virulent E proteins could have made. And then from the simulations, we saw that the SARS-CoV-1, CoV-2, and the MERS coronavirus, the more severe ones, remained attached to PALS1 for the whole 500 nanoseconds because the interaction was stable, but there was a less stable interaction between the less virulent human coronavirus 229E and NL63. So basically, we hypothesize with all of this in mind that this flexible part of the E proteins of the more virulent human coronaviruses allows them to form a more stable interaction with the host proteins inside the cell, and this is why they are most likely more severe compared to 229E and NL63, which are less able to form a stable interaction with PALS1, and therefore this is most likely why they are less virulent or less severe than the other three human coronaviruses. I'd just like to acknowledge my supervisors and co-supervisors for their help and support in this aspect of my project. And I thank you for your time and your attention. Please feel free to put any questions in the chat and I will answer them as best I can. Thank you.
Thank you very much, Dewald. Again, very interesting, and perhaps one of the reasons for the difference in virulence between these different coronaviruses. So super interesting. Let's see if I see there are some questions, but we'll deal with those in a few minutes because our last speaker for the first part of the session, she's our last, but definitely not our least, is Dr. Nompumelelo Nyembe. Born in KwaZulu-Natal, grew up in the North Coast within the villages of Zululand. She's always loved science and got a BSc degree in biochemistry and microbiology from the University of Zululand, and where she also did her degree in microbiology in 2011. She then joined the ARC in 2012 and obtained her master's in 2015 and her PhD in 2020 in biotechnology from UWC while working at the ARC. So really interesting. She is now a postdoctoral fellow at the Institute for Microbial Biotechnology and Metagenomics. Nompumelelo, welcome, and over to you.
Thank you very much. Good afternoon, everyone. Just gonna share my screen. All right, so my name is Nompumelelo Nyembe. I will be presenting under the Sustainable Development Goal number 3, which is good health and well-being. So my talk for today is application of genome-guided approaches for the discovery of novel drug candidates. Antibiotics are medicines used to prevent and treat microbial infections. As we all know, antibiotic resistance is one of the biggest threats to global health, food security, and development today. Antibiotic resistance occurs naturally, but the misuse of antibiotics in humans and animals is accelerating the process. A growing number of infections such as pneumonia, tuberculosis, gonorrhea, and salmonellosis are becoming harder to treat as the antibiotics used to treat them become less and less effective. Antibiotic resistance leads to longer hospital stays, higher medical costs, and increased mortality, which is why the World Health Organization implored the health sector to invest in the research and development of new antibiotics, vaccines, diagnosis, and other tools. All right, so among the examples of the superbugs that have been developed, that have developed resistance against multiple drugs is the methicillin resistant Staphylococcus aureus. The first drug against its infection was developed in 1940s, but soon the pathogen developed resistance against it, and many other antibiotics that were developed after then, it also managed to develop resistance. Another example is the Acinetobacter baumannii, a causal agent of chest, urinary tract infections, and many more. Out of the different classes of antibiotics that have been developed against it, such as from the classes of sulfonamides to the quinolones, the bacteria manages to still continue developing resistance over the years. The fast development of antibiotic resistance calls for a rapid response by discovering novel drug candidates. In the efforts towards combating the problem of antibiotic resistance, bioprospecting in marine environments has become one of the fast-growing initiatives towards discovering new bioactivities. Marine bioprospecting is referred to as the systematic search for interesting and unique genes, molecules, and organisms from marine environments with interesting features that could be used to society and also have a potential for commercial development. In bioprospecting, marine materials such as sponges are collected to harvest bacterial communities in them, and which are then studied further to harness their metabolic potential, either through culture-dependent methods or through genome-based methods. This is a sketch that explains the summarized approaches that are used in natural product discovery. The first one is the top-down approaches, highlighted in purple. These ones are the traditional that have been used traditionally, primarily to because they do not really require any sophisticated genome manipulation or genome sequencing. They just include diverse sampling from different environments and culture condition screening, and then comparative metabolic profiling. Whereas the genomics-based bottom-up approaches have been developed to unveil new natural products that were undetected under standard fermentation conditions. And these strategies, they leverage the powerful functional genomics and bioinformatics and genetic manipulation tools to identify and activate gene clusters of interest, either in native organisms or in heterologous hosts. Through several projects at the IMBM, we have gradually established a culture collection of greater than 3,000 isolates, which all have been biobanked. These culture isolates, they are derived from very unique marine invertebrate species sampled in Agua and Kalk Bays here in South Africa. Represented is a subset of these, with over 400 of these harboring some bioactivities. And these bioactivities, they include antimicrobial, anti-drug resistance, anti-cancer, anti-inflammatory, and neuroprotective activities. And these have been possible through the extensive collaboration with partners all over the world. As you can see from my left, this is where all the partners that we've been working with are indicated. Our approach is to mine novel biosynthetic gene clusters. From now onwards, the BGC, I'll call them BGCs or pathways, from the genomes of bioactive strains. We have novel species in our collection, and despite not being a large data set, there is very low redundancy, and more than 90% of the pathways are predicted to encode compounds that have yet to be discovered or characterized. This is the summary of the pathways that we are currently targeting for heterologous expression. We have non-ribosomal lipopeptides, we have lantipeptides, and then we also have the lactones, which are signaling molecules that we are planning to use towards eliciting the expression of pathways in cultured isolates and also in microbiomes, especially from the symbionts. As part of this talk, I will be giving a short presentation of one of my projects that use bottom-up approaches to identify and characterize the bioactive compounds produced, and this study reports on the discovery of novel film sparking containers produced by an uncharacterized marine sponge bacterial isolate called Marinomonas species. Following whole genome sequencing, the bioinformatic analysis using anti-smash, Bigscape, Corazon, and Sealinga led to the identification of a biosynthetic gene cluster or a pathway that is very much similar to the film-sparking pathway that was identified previously in the Acinetobacter species. However, the genes in the pathway of ours, only 47% of those genes share similarity with the known pathway in the Acinetobacter species. And this pathway is known to produce a film-sparking A cytophobe. And this film-sparking A cytophobe and its derivatives, they are currently being tested for antibiotic conjugate therapy against Acinetobacter baumannii. Although known, the Marinomonas pathway that is highlighted in blue was found to have a distorted synteny compared to the known producers. So the pathways that you see on top, they are from the non-producers, and then these ones are from our isolates and also the related bacteria. And also it was found to be very phylogenetically distant from the known producers, which makes it a very interesting pathway to us. And among other disparities that we've seen was the absence of 3 genes, the FIPS-B, FIPS-C, and the FIPS-D. And these genes were found only located elsewhere in the chromosome, and they are responsible for the production of the 2 and 3 dihydroxybenzoates, which is a major precursor for the biosynthesis of film-sparking A. With the differences observed at genome level, this study therefore investigated the film-sparking BGC with hopes of discovering novel compound structure analogs. Also, I forgot to mention that some of the genes that you can see highlighted in green here, as much as they are part of the biosynthesis, they seem to have little or no significant identity towards the pathways that are of the known producers. So we really wanted to harness what this pathway really is producing. So following fermentation, the extracts were analyzed using liquid chromatography mass spectrometry, which is LCMS. And from there, 8 peaks that are associated with film-sparking structures were identified. Out of these 8 peaks, we saw that 6 of them, they actually were novel structures with modification in the hydroxamide group R4 here. So the formation of the hydroxamide group in most hydrophores involve the function of decarboxylase of a decarboxylase enzyme, a hydroxylase, and the acetyl transferase. In Acinetobacter baumannii, or in Acinetobacter species, film-sparking A biosynthesis involves the decarboxylation of ornithine, and its breakdown product is modified to form N-acetyl N-hydroxyputrescine, and that goes into the production of the structure of film-sparking. Whereas here we report the possible decarboxylation of a lysine, and its breakdown products forming an N-acetyl N-hydroxycadaverine that is now responsible for the structures, the 6 structures that we see from our data. To validate this finding, supplementation with the labeled lysine, so this is just a heavy isotope lysine, where each carbon has an additional mass of 1 and nitrogen an additional mass of 1. Then this, when this was performed, it led to the mass shift of 188 to 195, which was on this compound of ours. And then that was just that that part only on the fragment that represent the hydroxamate group. And this diagram shows two major films-vaccine species, compound 1, which was previously identified in Acinetobacter species, even though we also see it in our own data. And then it also shows the compound 10, which is from this study and regarded as a novel films-vaccine structure. And then the peak, the third peak here shows it validates the mass shift from 589 to 596 on a peak representing compound 10 to confirm that the Marinomonas films-vaccine pathway incorporates lysine and not ornithine, which this part of incorporating lysine has not been recorded before concerning the films vaccine A and its derivatives. So therefore, this study reports the 6 new structures of films vaccine that are isolated from this Marinomonas species from the South African oceans. As a way to bring my presentation to a conclusion, I want to mention that in natural products discovery, there's a phenomenon referred to as a precursor-directed biosynthetic approach to diversifying the natural products. And this phenomenon exploits the natural flexibility of the biosynthetic pathway to incorporate unnatural building blocks, resulting in the production of various natural products analogs. So the classic example is erythromycin A. So when they modified some of the precursors, when they were trying to produce this erythromycin A, they found that they got a lot of analogs, and they were slightly different structurally to the original molecule, which is erythromycin A, a very well-known medicine that we have in our shelves. But what was interesting was that all these derivatives, they were also very bioactive, and they were also managed to enter into the drug discovery pipeline. So that is the nice part about it, is that when analogs are tested and are found to be bioactive, they can also enter into the same drug discovery pipeline, same as the lead compounds. So this was then very interesting to us, and we are hoping and we believe that the data that was produced in the study will contribute towards the ongoing antibiotic conjugates development efforts against Acinetobacter infections. As the, just to conclude, as the need to produce new medicine continues to rise, bioprospecting in extreme environments such as marine environments revives the hopes for novel drug discovery. And the applications of genome-based drug discovery approaches, they allow for effective pathway replication and targeted novel drug search. Using genome-guided approaches, we facilitated the process of replicating the target biosynthetic gene cluster, which is the films vaccine pathway that I spoke about, which led to the discovery of novel films vaccine structures to enter into the drug discovery pipeline. And finally, the identification of novel films vaccine structures increases the pool of compounds to be tested for antibiotic conjugate therapy against Acinetobacter baumannii. These are the references that we used in the preparation of this presentation. And I must say that this research was done at the Institute of Microbial Biotechnology and Metagenomics, the IMBM. So I would like to thank the past and the present members of the IMBM, the pharmacy, NRF, Blue Radiomics, and Science and Innovation for funding, and then the Central Analytical Facilities from Stellenbosch University with for their assistance with the analysis with LCMS data. So that is all from me today. Thank you very much.
Thank you very much, Nompumelelo. Very interesting. Definitely shows the untapped potential that the oceans have, and brings me back to my roots as I was part of IMBM. So thank you for acknowledging. So with that, I'd like to open the Q&A session. Please, you're welcome to put your questions on the chat or on the Q&A. We have a couple of questions already. Let me see. One question for Samantha from Asia. Thank you for such an insightful presentation, Samantha. Oh, can I invite all our panelists from the first half of the session to switch on their cameras, please? Now it's your turn to shine yet again. So Samantha, this one's for you. Do you feel that the South African population is genetically underrepresented in precision medicine?
Thank you so much for the question, Asia. Yes, definitely. The vast majority of genetic research is overwhelmingly done on European and Asian populations. And it's constantly now in precision medicine a game of us playing catch up. So, oh, they discovered these genomic markers, and now we can only see if it's present or relevant to our population, whereas we have to get to the point where we are the pioneers, like we discovered these genomic markers, now see if it's relevant to other populations, so to get to that point, that is, so yes, we are definitely underrepresented, and right now we are very far behind, and precision medicine or personalized medicine is the future of medicine. This is how it is going to be. One day you're going to go to the doctor, and based on your genetics, not based on how you look or based on anything else, based on your genetics, he will decide what treatment is best for you. And so it's time for us to play the catch-up game, or we're going to fall very far behind. So thank you so much.
Thank you, Samantha. Thank you. There's a question also from Asia to Devald. So number one, two-part question. Oh, I think, oh, it was answered already. I see. Right. No, it wasn't answered. So Devald, this one's for you. Do you feel, no, I'm missing them. Where have my questions disappeared? Yes, there we go. Number one, why should we be concerned about the E protein specifically? And could targeting this viral protein have helped us to deal with COVID more effectively? Or rather, let me change it as, could targeting this viral protein help us potentially with future coronavirus pandemics?
Sorry, thank you for the question, Asia. So yes, to your first question, why should we be concerned about the E protein specifically? Well, for me, because the E protein is involved in so many important aspects of the viral replication cycle. Firstly, assembling or producing new virus particles, as well as the release of those virus particles. If we can find a way to target the E protein and allow it to stop there already, well, in essence, we would stop the virus from producing more copies of itself. So that should limit the burden on the human body. And then secondly, because the E protein is involved in the pathogenesis or how the disease is established and then progresses, if we can address that as well, then, well, basically we're looking at two birds with one stone. There's actually quite a nice few studies that have already shown they take the whole virus, coronavirus, and then they remove only the E protein, and significantly less severe consequences than occurred when the virus then starts replicating. It can still replicate to a certain extent, but the amount of damage or pathology is significantly reduced when the E protein is absent. So I think the E protein is a very important target, and we can basically attack the virus from many different angles. So not just one, almost like combination therapy in chemotherapy, not just trying one angle, but more than one to target it at many different points. Regarding question 2, could this have helped us deal more effectively with COVID and potentially future pandemics? Very similar to my first answer as well. I think so, yes, because of the importance of the E protein in the viral replication cycle. I think it's definitely a good target that will help us on many levels. And we don't even have to start from scratch. There are already a few studies that have looked at certain drugs that show some reasonable promise in stopping the E protein from performing its certain functions. But I think there's a lot more room for improvement. There are other aspects of the E protein or other approaches not just small molecule inhibitors, maybe peptide therapies, for example, that offer different advantages, and then potentially future outbreaks as well, specifically in coronaviruses, because the E protein is present in all of them. It shows that it has to be there for specific function. If it wasn't there in all of them, well, then there's probably some other protein that could just substitute its function. But the fact that it is there, and the sequence itself, the subunits that make up the E protein, are quite well conserved as well. So it shows that this is important to the virus. It's there for a reason. So if we specifically target that, it should give us a good way of combating the virus.
Thank you, Deval. Very interesting. Thank you for that. I actually have a question for Sihle, who it was very interesting because you looked at a whole lot of different interventions. So you looked at the intervention, the data that has come out of it, what were they measuring, and basically realizing that there isn't sufficient, or at least they're not collecting the right data. There isn't sufficient evidence. So it's more of a qualitative feel that these interventions work rather than evidence. What would you recommend moving forward for new interventions, understanding that resources are constrained? Because when you implement an intervention, you just get going and you don't often think of how do I measure the impact of, how do I monitor? What are your recommendations?
My recommendations on that are the aspect of collaborative initiatives. So with most of the peer-led interventions that I'm seeing and the ones that I reviewed, it seems as though information-wise and knowledge-wise, they seem to be centered on just that specific intervention. There's no collaboration, there's no interventions that are utilizing already existing resources or trying to link health services, already available health services, and other alternative ways to actually implement the interventions. So on that note, it almost seems like all these interventions are more focused on their own intervention working, that they miss the opportunity for collaboration where, again, in terms of readily available information, that's actually missing. There's not much, even if you're trying to do a benchmarking of the different interventions that are, let's say, in the universities in Cape Town, there's still not that much information that you're getting from the intervention that's readily available for you to say, okay, here I have this intervention and this is my implementation process and this is how the capacity of it, this is what it does, this is the extent of its effectiveness. Can we collaborate on something? There's not that much information. So I think until people see it as just not collaborating with peer educators, but also collaborating interventions themselves, coming together and collaborating, I think the efforts for research will be broadened, and also some cost effectiveness will emerge in terms of funding and opportunities for funding, because collaboration, that's how most people would, what am I getting from you and what are you giving me as well? So I think collaboration is an important thing that is missing within these interventions.
Yeah, working within the ecosystem and pulling resources and absolutely. Absolutely. Thank you. Nabila, I also have one for you. Nabila is still there. So I find very interesting. I mean, I love the findings, and interesting that you saw an increase in the prevalence of falls on the elderly that had more than one medication, and specifically looking at antidepressants and anti-diabetic. And I find the anti-diabetic interesting because one would understand if you're not controlling your diabetes, you actually might get dizzy more often, fall. But if you are taking your medication, so I was just wondering whether there's any thoughts on the links with those two medications. Is Nabila there? I might have missed Nabila. Not there. That's fine. I'll catch with you. I just find it very, very interesting. And we don't have much time, but Nompumelelo, I did want to ask you, I loved your presentation because I actually understood it. I'm not sure whether the audience understood it, but it was very clear to me. And so in terms of the novel, so you have found these novel genes that within the pathway, and you're looking at the novelty. And I love how you made the link at the end with analogs, you know, to possible therapeutics by looking at the analogs. So looking at yours, it's a pathway you're looking at. Are you looking at which one might be the best target or the best one for the development of a therapeutic antimicrobial?
Yes, so basically the study is actually ongoing. The people who are working with Acinetobacter baumannii, the reason why they are doing the investigation of the siderophores is to investigate their ability to be able to join them with the antibiotics, and then so that when the bacteria accepts it inside, it's accepting a weapon that will work from within, because the antibiotics from outside sometimes, yeah, like I showed in the slide, development of resistance is just unending. It just keeps on going. So they are looking at therapies that can kill the bacteria from the inside. So the study right now with what they found from the Acinetobacter species is that it's a different kind of hydroxamate group that it forms. So our data is showing a different kind of hydroxamate group. So these hydroxamate groups, they are like the functional groups where one can conjugate the antibody. So depending on the chemical structure of that aspect, it can be better, it can be worse when it comes, or also it can depend on the drug that you're wanting to conjugate together. So for our work, we are not doing the testing, but because of the findings that we are finding, we believe that the data, once it get out there, the people who are doing this kind of therapy, who are testing these compounds, they can now, because what they are doing is they are not producing it for the therapy testing, they are not producing it again from the bacteria. They already know this is a structure, it is suitable for the receptors in the bacteria. So what they are doing is now just to synthesize it in the lab. And then once they synthesize it, and then they go into testing. So the information that we have, that we'll be getting out to them, that there is another possibility of a modified structure, it can actually help them. They can just go into the lab, synthesize this different structure and test it if it will be. So basically it's just enlarging the pool of the compounds that they can test again, and see which one is more effective.
Perfect. No, absolutely. Very important to enlarge the pool, because we all know how it narrows at the end. So the more you have at the beginning, the more likely you are to find one.
Exactly. Yeah.
Perfect. Thank you very much. I could ask a few more questions, but we don't have the time. But thank you to all of you. It's been very, very interesting. And it's really great to see the new generation of researchers really making a difference at UWC. It's been wonderful. I'd like to give you a virtual hand to all of you. Thank you very much. Very appreciated. And with that, we wrap up with the first half of the session on health, and we carry on with our second session on sustainable cities and communities. And we are running a little bit, not much, but a little bit behind. So I'm going to jump straight into it, and I'm going to introduce Dr. Ronelle Davids from the Faculty of Community Health Sciences. She's a senior lecturer at UWC, and she holds a PhD in social work. She's been working tirelessly within the deaf community, and she's going to be talking to us on the voices, specifically the voices of women who are deaf, and exploring their experiences of gender-based violence. Ronelle, over to you.
Thank you so much, Anna. My colleague is on the as well, presenting with me, Maria. I'm going to share my screen quickly with, okay, there we go. Sure. Okay, so Maria, I'm not too sure if you are on the platform. If you can unmute yourself.
Can you hear me?
You can just start. Yes, you can go ahead, Maria.
Hi, good afternoon, colleagues. Good afternoon. Thank you for this opportunity. This afternoon, myself and Dr. Davids will be presenting on Voices of Women Who Are Deaf, exploring the experience of gender-based violence. This is a collaborative research project between the Gender Equity Unit that reports to the DVC-RNI and Social Work, Department of Social Work from Faculty of Community Health Science. Can you just put on the slides? I can't see the slides.
Who will be sharing the slides for you? Is it Ronelle?
Ronelle, it was on. I don't know what happened.
Yes, Ronelle, we're no longer able to see your slides. If you can maybe just put them up again.
My apologies. I'm not sure what is happening here. Oh my word. Oh my word. It now tells me that it's in default. Oh my word.
Would you like to email me the presentation very quickly?
I will do so. Just give me your email address. Apologies, colleagues. I'm not sure what happened here now. Okay. Let me just go back on and just see if I can share again. Let me go back. I can see it coming up. Okay. Can you see it now?
It's coming up. It shows.
Yes, we can.
All right.
Can you put
My
in presentation mode?
I will do. Can you see it now?
Yes, we can.
Yeah, thank you.
All
Thank
right.
you so much. Sorry, colleagues. So yeah, the second slide can continue. I think looking at this, yeah, go back. Okay, the slide in front of you is the sign for gender-based violence when we're doing sign language, which were actually the language that we used during our research project. Go on. While all women are at risk of gender-based violence, deaf women are particularly vulnerable to gender-based violence due to their deafness, which heightens their risk of experiencing abuse and violence. Why or how? Because they cannot hear. They may also experience a lack of access to social networks, support services like medical or justice services, and information in their first language, which is South African Sign Language. They may also experience lack of information about what constitutes gender-based violence or intimate partnership violence because they can't hear. Also, the limited GBV literacy they have in terms of difficulty of not understanding the terminology or words used in gender-based violence vocabulary. And you will ask, but what about lip reading? Lip reading can be very difficult to learn, and it is impossible to catch everything someone says by simply reading lips. So it can be very difficult for deaf people just to read lips. And this is actually a persistent myth about deafness. Their experiences are not understood or heard. Deafness and GBV remains a largely invisible issue in South Africa. And as a result, there is very little research from which we draw from. While South Africa can draw on useful analysis and lessons from other countries, their applicability and relevance to South African context remains somewhat limited. So what was the rationale for the study? In order to provide effective assistance to the deaf women who have experienced gender-based violence, it is crucial to gain a better understanding of their experiences. So progress on the SDGs indicates persistent high levels of violence against the most vulnerable women and girls, leading to increased feelings of insecurity among women. In an effort to contribute to the Sustainable Development Goals, that's now number 3 and 5, which focus on good health and well-being and gender inequality, this research study presents the result of a study that aimed to explore the understanding of gender-based violence among deaf women and identify the factors that influence the experience of gender-based violence. Next slide. The next slide. Can you go on to the next slide, Renelle?
I think we have lost Renelle. Oh, there she is. Renelle, we have lost the screen share again.
Okay.
There we go.
Okay.
If you can put it on
go
presentation.
to the next slide. No, that is before that. Sorry, Brunel. Yeah, and then that's after the rationale. Okay, sorry about that. Oh, okay. The questions that we ask in this research project, we ask, what are these women's perceptions of gender-based violence? What is their understanding of certain GBV terminology? What support strategies are required to respond to the unique circumstances of women who are deaf? We conducted thus far 3 experiential workshops, and if you can, we've done one in southern suburbs that were 20 women. That was a mixed group, multi older and younger participants. In the northern suburbs, 18 women. We worked with 18 women, and then Atlantis, we had a smaller group of 8 women, but also an older group. And then one group is still outstanding in Paul, because our sample is for 60 women. Our study is situated in the community-based participatory research, community-based participatory research, which link community engagement activities with community-based participatory research, but also with learning and teachings. Communities are involved, so communities provide the reality of social and health challenges, and therefore provide the platform for learning and exploring the authentic challenges in the communities. As I said, the CBRP is a collaborative approach to research that involves all stakeholders throughout the whole research process. So we as academic researchers and the communities, we came together to foster co-learning, identify community needs, and address health problems. So there was shared power. We had to establish trust, also that enhances the strength and the resources, and through that build the community capacity, and also address the community identified needs and health problems. So in essence, our research is relevant and makes a societal impact. And it's society-led, and learning and teaching context of our students. Our team comprised of, as I said, it's a collaborative research. We have social workers, we have colleagues from the gender equity unit that specialize in gender-based violence. I think Ronelle comes from a background working with deaf women. And then also we have 3 community members from the deaf community. And that actually constitutes our team that is working on this project. So Ronelle will continue with the preliminary findings to the questions that were posed to our participants during our workshops.
Okay, thank you, Maria. So maybe just to go back to the previous slide, you will notice that in terms of our team, we had 3 women that were part of the team that were deaf. And one of the women was a relay interpreter. And I'm going to talk about that a little bit more as I go in terms of what the project that we implemented. So, for example, the questions that we asked, what do you understand by the following words? Like, for example, gender-based violence, or GBV. And so what you'll find is that they will understand the word violence, but they wouldn't understand the word gender. And so for us, we needed to explain what is the word gender for them to really understand. So the words were there, the signs were there, but the understanding behind what it meant was not there. I hope you understand what I'm saying. So for example, femicide, there was no idea in terms of what is femicide. And so what we needed to do is that even the sign language interpreter didn't understand what femicide was. But because we had a relay interpreter who was deaf, she was able to, to bring it over to the deaf participants, what is femicide. So a lot of co-teaching was happening, a lot of sharing of knowledge was happening while we were gathering data. Another word like intimate partner violence that we take for granted, the word intimate, they would understand the word violent, they would understand the word partner, but the word intimate, there's no sign for intimate. So it meant that we needed to unpack the word intimate. If it couldn't be done by the interpreter, we would then have the relay interpreter who I would have sat with beforehand in terms of pre-planning our workshop, and I would go through with her what is intimate, and then she would then explain those words in sign language. So you could understand that our data collection process did not take just about 1 hour, but it took maybe 2 to 2.5 hours, which actually meant that we were quite tired afterwards. The words force and dominate and control caused a lot of confusion when we asked them, do they understand what the words force, dominate, and control mean? And so what we had to do then with our 3 ladies who were deaf, they then role-played those words out for our deaf participants to understand those words, what they each meant. And so there was what came forward in terms of answering the question was that they had confusion about what these 3 words meant. Marital rape was another confusion. So the word rape they understood, but how can rape happen in a marriage? And that in itself, especially amongst the older participants, they couldn't understand the concept of marital rape. Where we had a participant or quite a few participants stating to us that no, rape cannot take place in a marriage, although we would explain it to them, but it was no, rape cannot take, my vagina belongs to my husband. That was the words that were used by 2 or 3 participants. The word abuse, it was easily to be understood, easily to be signed to them, but they didn't understand what was financial abuse, emotional, especially emotional and psychological abuse. So those words needed to be broken down. So the answer to that question is that no, I understand the concept or the word abuse, but I don't understand what is emotional abuse or psychological abuse. The same with sexual harassment. And then next slide, now I'm stuck. Can you hear me?
Yes, we can hear you.
You can hear me. All right. So it seems that now I don't know what is happening with my presentation now. And so it's stuck.
We can see it.
Okay, yeah. And so let me give you an example. So here I wanted to play the video for you. And so you can hear we are using the sign language interpreter. Okay, and here we are using the relay interpreter. Okay, so this person next to the person who is voicing over is a deaf person, and she was just relaying words like femicide, intimate partner, violence. And so that is just to give you an example in terms of how we use an interpreter as well as a relay interpreter who is deaf. And so what makes it difficult for you to understand gender-based violence issues was some of our questions that we asked. They were saying that service providers don't know how to work with deaf people. There are no interpreters available. People think that we can lip read. We don't understand the words that are used. They don't understand us. If they don't know these words, how do we express ourselves? So if I don't know these words that a counselor or anybody is using, how are we then able to express ourselves? We also asked them to tell us about any challenges that deaf women would experience when seeking help. Again, the issue of sign language came up, sign language interpreters. But then again, if you look at sign language interpreters in the South African context, we don't have sign language interpreters who are trained in gender-based violence. We would just source an interpreter who is available simply because of the scarcity of that resource in our country. And so we don't have police sign language interpreters at police stations or at hospitals or at courts. So for example, just recently, we had a young deaf lady who was raped by 3 perpetrators. Unfortunately, when she reported the case to the police, there was no sign language interpreter. When it came to the court, they then threw out the case simply because the stories or the story that she told the police, but that which she had written down and that which she was telling the court were 2 different stories. The deaf were also saying, the deaf ladies were saying that we can't go to organizations, and we don't want to go to organizations that cater for the deaf because everyone there knows each other. And so we would rather want to go to an organization like Rape Crisis where nobody knows us. Why can't we have access to those services like any hearing person? Okay, so they've made recommendations, and I'm just trying I'm mindful of the time. Recommendations based on the comments from our participants, but also linking it to the significance of the study. What is important, what they were saying, and the significance is that it underscores the importance for public servants to receive sign language training. Also about deaf culture. It's not just about knowing sign language, but you need to understand deaf culture as well. And they specifically spoke about the police, the health sector, as well as the justice system. They also felt that there must be research done with males who are deaf, and what about their perceptions, and what is their perceptions about gender-based violence, and what is their role within gender-based violence. So that in itself is something that we are looking at to expand and to continue this research next year, but to look at the perceptions and understandings, exploring the perceptions and understanding of males who are deaf. And they felt that there should be more collaborations with the deaf community about their needs. And we also need to include various stakeholders. So when various stakeholders, they were saying, have meetings, have training, and so forth, it's important that they do invite the deaf. And so our learning, our experiences, or our takeaways from this research that we've done. And so language was a big issue. Yes, we made use of a sign language interpreter. However, we felt that there were different dialects of sign language. And so, for example, going to Atlantis, the majority of them went to a school that was taught in Afrikaans. And so we would find that we were signing, but then we would have to obviously change the words in Afrikaans. And so the signing was there, but also the understanding and the meaning we had to convey sometimes into Afrikaans, which made it quite difficult. Sign language is a visual language, and often we had to use signs that was very visual for them to understand. We used pictures. However, from the research and from the feedback that we received was that sometimes the picture itself could convey a different meaning to what the deaf person understands. Then the use of a sign language interpreter, I think is very important. This is another aspect of research that we can look at in the next coming years in terms of using the correct sign language interpreter, using a female interpreter. However, we need to think at how does, what we are, the collection of data and the stories and the experiences that we hear from our participants don't affect our interpreter. And obviously we need to have this debriefing sessions after our workshops that we have. As I said, data collection does take much longer than just you going collecting data without using a sign language interpreter or trying to provide the meaning so as the person can get the understanding in terms of what is being meant. when we ask a question. So summary for us, universities are to become agents of change and therefore not viewed as ivory towers any longer. Communities and stakeholders become part of our research. And so how do I take this research that I'm working and take it back into my classroom? So for example, in the area of social work, when my students are doing maybe practical placements, can I place a student who is in a field like this where they are working with people who are deaf? And so how do I take my research and place it then back into teaching and learning? We cannot underscore the value of community-based participatory research as a way of researching and learning together with community members and community stakeholders. Research is not an event, and I want to stress that. Research is not an event. We're taking these results and we want to place it and take it back. These findings, take it back and place it back in our community and wanting to make a difference. Bridging the gap between deaf women, victims of gender-based violence, and public policies on access to justice. We're talking about access to justice for a vulnerable group. So attaining the SDG goal 5.2 becomes a practical and attainable through the implementation of this project. So we see this project as some form of a goal or some form of way in terms of how do we meet the SDG goals to ensure that there's more equitable and a sustainable world. And so the next phase, I just wanted to give you an example of what we really want to do with the data that we've now gathered and really put it onto a video, because as I say, sign language is a visual language. It's not, writing, it's not going to work. So how do we take what we have and put it visually so that the deaf can use it and do training amongst their own amongst deaf women, amongst young teenagers, and amongst their community in terms of using these findings. So I just wanted to give you an example of what we will be doing. This is what they've done in Britain. And so we're going to be doing something similar in terms of the results that we have and making it more, South African context in terms of the South African sign language that we will be using. So I'm just going to give you a little glimpse in terms of what we will be doing with the findings that we have. So this is the word gender-based violence. So yes, here it's been signed or it is spelled out in the alphabet, okay? And then that's the sign for gender-based violence. Or it could mean gender-based violence like that. That's another way of signing it. And then the definition, what is gender-based violence, so that we can then provide the understanding. So we will be doing something similar to this with our findings so that we can then disseminate our findings, not only in the deaf community, but also to various stakeholders, like I say, health, police, and the Department of Justice. All right. So thank you very much for the opportunity to present our project.
Thank you very much, Ronelle and Maria. That was actually amazing. It's something that we don't think about. I think we all realize that people with disabilities are at high risk for violence, women with disabilities for gender-based violence, but we don't even realize that it's not just because they don't have as much access to information, awareness, it's because the vocabulary is not there. So, I mean, that's very interesting. Thank you. I think I'm going to be presenting our last speaker for the day, and then we will open up for questions on the second half of the session. I'd like to invite Ms. Elizabeth Banya from the Faculty of Natural Sciences, who will be talking about women's household drinking water choice and time to get water sources in the rural areas. And this is from evidence from 2018 Nigeria Demographic and Health Survey. Elizabeth, over to you.
Good afternoon, panelists. Good afternoon, attendees. Thank you for the opportunity. I'll just quickly share my screen. Can you see it on your side?
Yes, we can.
Okay, thank you. My name is Elizabeth Daniel from the Department of Statistics and then Population Studies. And my presentation this afternoon is the factors associated with the time it takes to fetch water for household use among women in Burundi, insight from 2017 Demographic and Health Survey. And I'll take you through my introduction, background of the study, problem of the study, and objective, significance of the study, and the methodology. And women and girls aged 15 and older are primarily responsible for water collection in 7 out of 10 households and spend more time doing it each day compared with 3 in 10 households for their meal care. World Health Organization 2023. In many households, women and girls are the primary users, providers, and managers of drinking water, since they spend more time acquiring clean water for their daily chores like cooking, like cleaning, laundry, and caring for their family. However, this can result to women spending less time spending less time learning, like their educational aspects and their productivity. According to World Health Organization 2023, globally 1.8 million people live in households without water supply on their premises. And on the right-hand side of the slide, it's images of women fetching water, images of women fetching water for their households. And next slide. In Burundi, about 70% of the population lives below the poverty line, and it is ranked among the world's least developed country. And in Africa, women and children are assigned different roles, different duties, especially women in the rural areas. And fetching water has been, discovered or has been indicated as part of the duties or the tasks of women daily. The improvements in access to water at national level conceals disparity between urban and rural population and between provinces. And then this is also an image from UNICEF Burundi 2023 from one of the province or region, Sibitoke. This is a tap or water tap collection of women for their household use. According to World Health Organization and UNICEF report 2022, women 63% are responsible for water collection than men 26%. 1.2 billion people in sub-Saharan Africa who still depend on water collection compared with only 12% of the population in North Africa, in Northern Africa and Western Asia, and just 3% in Latin America and the Caribbean. And this is another image of young children, young girls carrying water on their head in a village in somewhere in Ghana. And women are 4 times likely as men to fetch water in sub-Saharan. And the problem statement states that research has shown that women and girls are responsible for water collection in most households. This is a situation that requires girls to walk long distances in search of clean and safe water. Long travel time between the house and the water supply sources takes lots of time and effort. Women and children bear much of the burden, especially these include low enrollment rates in schools, skipping classes, and absenteeism at workplaces. And long travel times between the household and the water supply sources takes lots of time and effort. Women and children bear much of this burden. General objectives and specific objective. As a result of a large number of women and young girls affected by the lack of clean water and long travel time to water supply sources. The overall objective of this study is to provide a more comprehensive description of women's water sources, shortage at household levels and travel time to water sources in Burundi, to identify the differences and the similarities of access to drinking water among women heading household in Burundi, and to explore the factors that influence women's household drinking water in Burundi, to examine the relationship between women's demographic characteristics and access to water for household use, and to also examine the travel time amongst women in Burundi. And the methodology and data collection that was used in this study, the study used a quantitative research method, secondary data that was derived from demographic and health survey conducted in Burundi in the year 2017. The data was done in 3 stages: the univariate analysis, bivariate analysis, and a multivariate analysis. The study only considered women heading household. Women heading household has the population study, as a study population. And the data set, the sample set that was considered in this study was 4,728 women aged 15 to 49 years in Burundi. And the survey used 4 types of questionnaires for data collection. The first one is the household questionnaire, the individual questionnaire, individual make questionnaire, and the biomarker questionnaire. But this study emphasized on the household questionnaire, which had variables like social demographic characteristics of women, gender, place of residence, educational level, marital status, occupation, and so on. And the significance of this study examined the access of women for household water. This to examine women's access to water for household use. The study was designed to evaluate a broad range of factors associated with women's household in both rural and urban communities in Burundi. Understanding the factors contributing to women's access to water is crucial, and achieving a successful and safe water supply in Burundi by taking into consideration women's age, ethnicity, population group, marital status, and educational level. To also examine these factors can help to identify and address any existing issues and potential barriers that may prevent women from accessing safe and reliable drinking water. And here is a graph of a univariate analysis, the travel time to water sources. And as we can see on the graph, 62% of the population travel for 30 minutes to water sources, 62% travel for 30 minutes to water sources, followed by 16% of the population traveled for 1 hour to get to water sources. And then 16% of this same population also have water on premises. That is, they have water within their household. And then the second graph on the right, which is the bivariate analysis, the place of residence. We can see on the graph, on the bar graph, that we have the urban and the rural, and then the urban, which is the green, 79%, almost 80%, they have water. 80% of urban women have water on premises, as compared to 21% of rural women that have water on their premises. And then women that also worked, women that also traveled for 30 minutes, we can see that the rural women, majority of the rural women traveled, 86% of the rural women traveled for 30 minutes to collect water for their household. And the same applies to the next. 90% of rural women traveled 1 hour to collect water for their household. And then 92% of same rural women travel for about 1 hour, 30 minutes, 90 minutes to their water collection point. And then women that traveled for 91 minutes plus, it was discovered, it was seen that rural women, 88% of them traveled for over 91 minutes just to get water for their household use. And this is another bivariate analysis between educational level and travel time. And you can see that people that have, women that have water on premises, the green tells us that women with secondary education, 53% of women with secondary education, they have access to water on their premises, and followed by 25% of women with primary education, they have access to water on their premises. And going to the next, you can see, okay, sorry, on the women with water on their premises, 11% of women with higher education, 11% of women with higher education also have water on their premises. And the next one, for women who travel for 30 minutes, you can see that 38% of women with primary education, and 36% of women with no form of education at all, they travel for 30 minutes. And the next one, you from the entire graph, you can see that women with primary school education and women with no form of education, no education at all, they are majorly seen as the population that traveled the most across all the travel time. For 1 hour, they are there. For 1 hour, 30 minutes, which is 90 minutes, they are there. For over 91 minutes, they are there. While on this side, women who had access to water on their premises, like I said, 11% of women with higher education had water on their premises. But when you look at the next one, for 30 minutes, women that work for 30 minutes, you can see that women with higher education, they are not even found in this group. The same thing, women that worked 1 hour, which is 60 minutes, women with higher education, they are not found in this group. And so on, they are not found in this group. So say that education also has an influence on access to water and how women travel to access water for their households. And the binary logistic regression factors associated with women's access to water on premises in Burundi. This is it. The urban area, we can see that women are more likely to access drinking water by 6.104 times than the rural women. They are more likely to access water on their premises than the rural women. The urban women are more likely to access drinking water on their premises as compared to the rural women. And to educational level, we can see that women with no education, women with primary education, women with secondary education, they are less likely. This negative value tells you that they are less likely to access water on premises, to access drinking water on their premises as compared to women with higher education. And then the table 2, factors associated with women's access to water outside the dwelling unit. This is the point where women have to travel outside their household. And then on the urban area, we can see that the urban women are less likely to access water outside their household. You can really see when urban women traveling like so far to access water. It is majorly common or majorly seen among the rural women. And then coming on the educational level, you can see that 0.097 and 0.596, 1.809 positive, seems that it tells us that this group, the no education, primary education, secondary education women are more likely. They are more likely to access water outside. They're more likely to work, to travel long distances to access water compared to higher education women, And next slide, the conclusion. The study findings demonstrated that the majority of women with secondary school education access water on their premises, 53%, followed by primary school women, 25%, and those with higher education with a rate of 11%. Women with primary school education recorded the highest among those who traveled. Like I said earlier, women with primary school education and women with no education recorded highest women who traveled across all travel time to access water. And among women who spent 90 minutes collecting water, women who had a primary level of education and women who received no schooling recorded the highest with 42% and 36%. The study shows that women with no schooling and women with primary school education worked across all the travel time, collecting drinking water for their household. Water collection is a major activity for women, which can in turn affect women's education, since it consumes a significant amount of their time. And the chi-square test shows that there's a significant relationship between travel time and educational levels, since the p-value is less than 0.05. And the chi-square also, the chi-square test also shows a significant relationship between travel time to water sources and types of place of residence. Types of place of residence, table 1, urban women are more likely to access water on premises than rural women by 6.104 times. I said that earlier. And women and children and women with primary school and secondary school education were less likely to access drinking water on premises by 0.551 and 0.164 times than women with higher education. And table 2 regarding women living in urban areas of Burundi were less likely to access drinking water outside the premises by 0.164 times than women living in rural areas. As previously mentioned, another variable with a positive influence on women's access to drinking water outside the premises is education. Women with primary and secondary education were more likely by 1.816 and 6.104 times to access drinking water outside the premises than women with higher education. Thank you very much. Thank you for your audience. Thank you for listening.
Thank you very much, Elizabeth, and apologies. I had it as a survey done in Nigeria, but I see it is Burundi and not Nigeria, a very different country. So apologies for that. Very, very, very interesting numbers, I have to say. Obviously, I'm not an expert in numbers, so I'm glad that you are there. But it's amazing how you've shown that, you know, that link between education and the access to water, which also is a bit of a vicious circle, I guess, where you don't have access, and you often don't do your schooling because you have other chores such as getting water, and that's so it's almost which one goes first? Education, access to water, or access to water, therefore not allowing education? That's my question to you now. What are your thoughts?
Say that again.
So your thoughts around, the level of education has a link to access of water. The more highly educated women have access, or more easier access to water, than the less educated women. And yet at the same time, a lot of the times the women are not educated because they actually have to go and get water and therefore do not have time to go to school. So it's a circle that cycle will never end. No. So any ideas on that?
Okay, what I say is the time women spend on water, the time they spend in terms of traveling to water sports deprives them, just like you said, from attending class or perhaps going to school late. And then at the time they arrive school, or at the time they return from school, they are too tired to visit their schoolwork that they have perhaps done in class, and they return again back to water fetching. So you discover that even in the urban areas, you don't have as much water scarcity as much as in the rural areas. For women in the urban areas, they have access to water majorly within their premises. That doesn't require them to walk long distances to get water, as to 30 minutes, 1 hour. Why the walking thing, the travel thing, it's majorly seen among women in the rural areas? Perhaps it's because their access to water is poor, in the sense that their houses are built far from the water point, which is not so in the urban areas. In most urban houses, they have water in the house, but in the rural areas, they have to step out of their house to get water. So if they are to visit such situation, so water now should be very close to women in the rural area. In that case, they will have the time to go to school. They wouldn't say, okay, I'm going to get water, and that's why I'm missing or skipping classes.
Yes. Yes, no, absolutely. You know, there's a saying that it says the hardest working person in the world is an African woman, but I think based on your studies, it's actually a sub-Saharan African woman. Thank you very much. Ronelle and Maria, I've got a couple, just a couple of questions. Very, very interesting. So I used to work with Prof. Bill Tucker on an app that he was developing for the deaf community, and it was specifically for pharmacy and for home affairs, you know, because it's a reality. The most basic functions are a chore, because most of them are illiterate and they speak one language only, and that is sign language, South African Sign Language. And what I found interesting is the relay interpreter. Can you tell me a little bit more about that? I think it's fascinating, because just having a non-deaf interpreter, you might actually lose that communication. Can you just tell me a little bit more about that?
All right, thank you. Thank you for your question, Anna. And nice to hear that you've worked with Bill, because I think we work in the same circles when it comes to the deaf community. So yes, so the relay interpreter is the person that normally is between the deaf person and the sign language interpreter, who is a hearing person. And often, because I said earlier that many of our interpreters are not trained specifically within maybe a jargon or in a field that you are busy working in. And they might not have the background. So especially if you are not a coder, which is a child of a deaf adult. And so you haven't been brought up within that, you know, that background of deafness, or the culture, let me say the culture of deafness. And so you might know the signs and so forth, but there are various dialects of signs. Yes. And so when you have a group of deaf people that come from all different provinces, and maybe some from African countries as well, that have, for example, maybe from an African country, Malawi, Zimbabwe, they've got their own sign language. Deaf people can cross over that barriers. It's sign language, it's sign language. You've got South African Sign Language now as a 12th language, but sign language to them is sign language. So this deaf person takes that language. She knows how to break it down. Our interpreter, especially our relay interpreter, working in the field of social work, working in the field of you know, with deaf people, and very familiar with the signs, and with deaf, the array of different deaf people from different backgrounds. She's able to change that and to break those words right down into gestures, into facial expressions, whereas an interpreter might just stand there and, you know, give the meaning over. And there's an understanding, but to break it down right to the core, where the most illiterate person in that group would understand it. So it's just not providing the word and the meaning of the word, but she breaks that word right down, and bring it down to the practical meaning. That's what I'm looking for. It's practical meaning that she puts onto her hands. And that's really the role of the relay interpreter that we use.
I think it's a fantastic initiative, because we often don't think about that. And you know, it comes to when people who speak language, or interpreters, either language interpreters, and there's a very clear difference between someone who's a native speaker, someone who's learning the language, and the best interpreter is the native speaker in both languages, because, as you said, language is actually a culture. Everyone who speaks a language thinks a different way, because through that language. So if you are an interpreter, a sign language interpreter, but you are either not deaf or you are not a child of deaf parents, you don't understand that that culture, as you said, the thinking, you know, how you think. So I think it's brilliant, especially with such sensitive issues that you are discussing, where you have to get the understanding. And sign language is a very emotional language because you, as you said, you use your face, you use your everything to portray that understanding. So I think it's a brilliant intervention. I mean, I can imagine that it took a lot longer because of it, but I think the down the road is a much more solid results to what you're doing, an actual change. So well done.
Thanks a
I'm
lot,
very impressed.
Manana. Thank
really.
you.
So with that, and Maria, you know, I'm always very impressed with what you do. I think our last speaker somehow did not make it. So this is the end of the session on communities and urban infrastructure, etc. Thank you very much to all three of our speakers. It's been brilliant. Thank you to our previous panelists on the health. Really interesting. I always leave these sessions feeling so amazing about being part of UWC, because we're not just creating new knowledge, we're doing it to make a difference. And that's exactly what the SDGs are about. So thank you, everyone. Thank you to our audience for hanging in there, and have a wonderful afternoon, everybody.